the normal sugar and chloride content in the CSF, and the virus can be isolated from the CSF. Treatment of meningococcal meningitis. When we suspect a case of meningococcal meningitis, we take the CSF examinations and we must start empirical treatment immediately without waiting for the results of investigations. Because the cultures of the CSF, to be sure from the presence of the meningococci, may take 2 or 3 days, and postponed treatment may be critical for the patient. So the treatment should start at once before waiting the investigation. Then the treatment could be corrected and adjusted according to the results of the culture and sensitivity later on. The empirical treatment include antibiotic therapy, empirical antibiotic therapy, which is variable according to the age group of the patients. In neonates, ampicillin sulbactam that's given in a dose of 200 milligram per kg per day intravenous in a divided doses every 4 hours. Or third generation cephalosporin such as cefotaxime 200 milligram per day intravenous in a divided doses every 4 hours. One of two plus aminoglycosides such as amikacin in a dose of 15 milligram per kg per day intravenous in a divided doses every 12 hours. In children up to 6 years, the empirical treatment include ampicillin plus third generation cephalosporins. For all other age groups, we give third generation cephalosporins such as ceftriaxone or cefepime 1 to 2 gram every 12 hours intravenous, or cefotaxime 2 gram every 46 hours intravenous, plus penicillin G or crystalline penicillin 4 million units every 4 hours intravenous, or vancomycin 1 gram every 12 hours intravenous. What should we know about the treatment of meningococcal meningitis? Number one, all medications must be taken intravenous route, must be taken by intravenous route for at least 14 days. And these 14 days should include at least 1 week afebrile. Combined antibiotic therapy is mandatory. Although penicillin does not cross the blood-brain barrier, but in the case of meningitis, it can cross blood-brain barrier because the permeability of the blood-brain barrier is disturbed in the case of meningococcal meningitis. The general treatment include proper nursing, feeding, and analgesics. The third line of treatment is the prophylactic treatment, and it's given to anyone who is at risk for the meningococcal infections or the contacts of the patients with the meningococcal meningitis. We can give rifampicin 600 milligram twice daily orally for 2 days to all exposed persons. Meningococcal vaccine, which is a live attenuated vaccine, is given especially to children. 0.5 millisubcutaneous. It gives immunity for 2 to 3 years. In a case of tuberculous meningitis, the treatment is the antituberculous drugs, including the pyrazinamide, ethambutol, isoniazid, rifampicin, and vitamin B6. We should remember that the antituberculous treatment should be given for 1 to 2 years, except the pyrazinamide and ethambutol for 2 months only. Adjuvant corticosteroids can be given for 6 weeks, sometimes longer. Treatment must be started as soon as there is a reasonable suspicion of the diagnosis. The second type of CNS infection is the encephalitis. Encephalitis is the inflammations of the brain substance. When the spinal cord is involved, the term is called encephalomyelitis. And this encephalitis may be viral encephalitis and encephalomyelitis, suppurative encephalitis, which is called the brain abscess, and demyelinating encephalomyelitis. Now we will talk about the most common form of encephalitis, which is the viral encephalitis, which may be primary encephalitis or secondary encephalitis. In a case of primary encephalitis, it's caused by viruses attacking the central nervous system, such as encephalitis lethargica, rabies, poliomyelitis, and inclusion body virus. In a case of secondary encephalitis, it's caused by organisms, either virus, bacterial, and parasites, which invade the nervous system from other organs. It may be viral, bacterial, and parasitic. Viral, such as post-infectious, as in mumps, glandular fever, influenza, herpes simplex or zoster, and HIV. Post-vaccination, as in rabies and the smallpox vaccine. Bacterial encephalitis, such as typhoid and bacillary dysentery. Parasitic encephalitis, such as malaria, toxoplasmosis, and leishmaniasis. The pathology of encephalitis: the virus attack the ganglion cells in the gray matter. The nerve cells show destructive changes. Secondary glial and vascular reactions in the form of microglial proliferations and perivascular infiltrations with inflammatory cells, mostly lymphocytes. The meninges may show very mild inflammations. The clinical pictures of the viral encephalitis: the patient is manifested by number one, acute onset of flu-like symptoms as fever, severe headache, blurring of vision, vomiting, and confusion as manifestations of increased intracranial tension. Sometimes the patient is presented with seizures, epileptic seizures. Personality and mood changes may precede the onset. Younger children or infants may present with irritability, poor appetite, and fever. The neurological examinations usually reveal fever, drowsy or confused patients, stiff neck due to irritations of the meninges covering the brain. The viral encephalitis is diagnosed through number one, the clinical pictures. Number two, neuroimaging, CT and or MRI of the brain may show focal lesions at the most affected site of inflammations, for example, temporal lobe lesions in a case of herpes simplex encephalitis. The CSF examination and is characterized mainly by increased CSF pressure. The appearance of the CSF is clear. The number of cells in the CSF is high and mainly lymphocytes. Finally, PCR or polymerase chain reaction is the most sensitive rapid test for the detections of the virus in the CSF. This is an example of the MRI that show hyperintense lesions presence in the temporal lobe. As we see, hyperintensity in the temporal lobe, which is called temporal lobe lesions in a case of herpes simplex encephalitis. The treatment of viral encephalitis include proper nursing, antibiotic, vitamins, and tonics. In a case of herpes simplex encephalitis, acyclovir is given in a dose of 10 mg per kg by intravenous infusions over 1 hour every 8 hours for 14 days. Ganciclovir may be used in a case of cytomegalovirus or cytomegaloviral encephalitis.